Thank you so much for having me, Angela. I'm a big fan of Angela's work, especially early on when I was thinking about these themes in terms of how to situate patient narratives in scientific frameworks. There weren't actually a lot of work that is done on psychiatric narratives and their value. And Angela's work has been a big inspiration. And similarly, I'm a big fan of her work. And I'm very delighted to be here. I'm also a big fan of your institute. It's kind of a dream place for me as a kind of model, I think, for how interdisciplinary work could be in the space of like health and humanities and science. So, as Angela said, my book just came out in April, and I have been thinking about these themes for a very long time, and I'm very happy that it all came together in the book. So today I'm going to primarily kind of walk you through some of the fundamental arguments that I develop in the book, kind of give you a broad introduction, and then we can go into more depth and detail in the Q&A part. So, when I think about psychiatric knowledge, just in terms of like what is psychiatry as an area of medicine and science trying to do, I kind of want to like broadly form this as the goal of developing psychiatric knowledge. So what do I mean by psychiatric knowledge? Basically, knowledge about mental disorders in a way that we can develop interventions on these mental disorders and help improve the lives of those who are experiencing mental disorders and want to continue to flourish. So when we look at the sources of knowledge of mental disorders, there are three sources. So one comes from what I broadly call scientific practices. So especially in places like the United States, the Diagnostic and Statistical Manual of Mental Disorder, which provides the criteria for mental disorder diagnosis. That's the product of some kind of scientific research, right? We can say similar things about the ICD, International Classification of Diseases. Other forms of scientific practices that aim to develop an understanding of mental disorders are drug research or some kind of more basic science research in genetics or neuroscience and so on. So these are all scientific practices. There's also another kind of form of knowledge that comes directly from clinicians' direct encounters with patients, right? I call it these clinical practices. And this includes not just psychiatrists when they are encountering and treating patients, but also, again, in the context of US, like social workers, nurses, and other kinds of healthcare professionals, counselors who interact with patients and form a body of knowledge, sometimes implicit, sometimes explicit, that we can see in publications and so on and so forth. The third source of knowledge about mental disorders or experiences of mental disorders is what I'm going to kind of broadly classify as like the self. And this basically involves both the first person narratives of people who encounter or interact with the kind of medical systems when it comes to their mental disorders, and as well as kind of research on the topic of the self that takes place in cognitive sciences, social sciences, or areas like clinical psychology. So, of course, like I produced this book in the United States. So a lot of the kind of my experience and encounter and observation of scientific research in psychiatry in the States is might be slightly different from the UK, because I always think that UK has been a lot more progressive and open in terms of allowing patients' narratives to have a space in psychiatric epistemology. But at least in the kind of context of scientific knowledge, there has been an under-examination of self-reports, an overemphasis on scientific and sometimes clinical practices in producing knowledge about mental disorders. And I think that's a lost opportunity. In kind of today, I'm basically going to kind of provide you an overview of the book where we'll talk a little bit about what I call the neglect of the self in psychiatry in terms of twin failures. And then I will basically say that self has not been a target of research in science, in scientific psychiatry, and that has resulted with various epistemic and ethical costs. And then I will try to bring the self back. But when I'm trying to bring the self back, there's a big kind of argument against this idea that the self should be part of psychiatric research, which is basically that psychiatry is trying to be science, and studying the self is not scientific. Therefore, that's just not a good goal. But I'm going to argue that actually it is possible to imagine psychiatric science that focuses on the self, and that will, motivate my development of the multitudinous self model. And I will end with some concluding remarks. So, mental disorders are experienced in the form of anomalies in self-related capacities and attitudes, right? Each kind of mental disorder can be referred to or understood in terms of changes in like self-control or feelings of self-efficacy and so on and so forth. And in that sense, mental disorder deteriorate individuals' relationship with themselves and others. And in traditions in general mental health care, like social work, nursing, psychotherapy, broadly acknowledge this, right? If you talk to a clinical psychiatrist, they will say, of course, like we are dealing with the patient's kind of self experiences. However, when you look at the kind of psychiatric knowledge, scientific research in psychiatry, the self has rarely been the object of contemporary research in psychiatry. And this has been costly, not only for scientific research, but also for clinical interventions and patient self-understanding. So there has been an overemphasis in biological or neurological underpinnings of mental disorders when we think about mental disorder research, and underappreciation of the concept of the self. And that's what I try to fill in this book, The Gap. So when I think about the neglect of the self, I mean it in two different ways. I call these twin failures. One is the neglect of the concept of the self as a research target. And this is not surprising in so many ways, because the concept of the self has a very complex history in the sciences and philosophy. So if you're kind of coming from a philosophical tradition, you might wonder, that, well, isn't the self like something like the soul, like that there's this like transcendental idea of the self? Like, how are we going to study that scientifically, right? Or you might say, well, there's no such thing as a self. Like, why are we going to study that? But when I think about the self, as a research target, I think of it mostly as a kind of a tool that is represented and studied actually by some of the cognitive and social sciences, right? There are lots of social scientists or psychologists who talk about self-confidence or self-efficacy. So there has been contexts where the self has been a research target. Yet psychiatry has not really taken those studies seriously. And another big, kind of what I think of as a failure or a missed opportunity for psychiatry is the neglect of self-reports. So I take self-reports of individuals with encounters of mental disorders to be approximations of subjective experience. And even though there's some kind of, maybe more so not than in the past, an acknowledgement of the value of patients' self-reports, there hasn't been any effort to systematically integrate individuals or patients into psychiatric research. And the reason for that is, especially in the context of manuals, development of manuals like the DSM, is that, well, psychiatry, again, is trying to be a scientific enterprise, and involving patients and their self-reports in that process will basically defeat our goals to establish ourselves as a properly scientific and objective discipline. So I'm just going to kind of give you a quick summary of this beautiful picture that I created, but I'm not going to go into detail. When you look at the history of psychiatry, at least in the context of the United States and the evolution of the DSM, you see that early on, when the diagnostic manuals first created, there was a very kind of Freudian psychoanalysis analytic orientation of representation of mental disorders. I mean, this was not surprising because psychoanalysis was a dominant framework to think about mental disorders at the time. So starting in 1960s and 70s, there has been an increase in the criticisms of psychoanalytic framework in thinking about mental disorders. I mean, these range from views that psychoanalysis is not scientific to worries about, the reliability of diagnostic criteria, and wanting to kind of ground the description of mental disorders in observable phenomena. And at that time, in psychology, psychoanalysis was in competition with behaviorism. And so, there was that kind of battle going on. And psychiatry moved away from psychoanalysis starting in 1980s with the publication of the DSM-3, and adopted a more kind of logical positivistic framework and behavioristic framework to kind of articulate mental disorders. So again, when I take like as a document of psychiatric epistemology, the DSM, and you see the evolution in the categories where mental disorders are represented in terms of behavioral changes and differences. While this change actually generated a lot of productive and interesting research, what is kind of surprising to me and a missed opportunity is that during that time in psychology, as a cognitive and social science, there was an attempt to find a middle ground between psychoanalysis and behaviorism, with the idea of focusing on concepts like self or the mind in a way that really integrates those kind of more behavioristic approaches and psychoanalytic approaches. Yet psychiatry kind of turned away from that, and there are multiple reasons for that. We can kind of talk more in details. Similarly, another way in which the self has not been kind of a subject of research is what I think of as neglect of self-reports. So as a new PhD students back in early 2000s, and I don't know, maybe I was just very naive. I really wanted to understand mental disorders and think about how mental disorder experience kind of disrupts individual self experiences. And I thought, well, I could read first person memoirs of people with mental disorder diagnosis and experiences to, improve my understanding of mental disorders. And then I realized that this is not actually a straightforward or an accepted form of methodology. At least not, it was not the case in early 2000s. Yet when we look at these memoirs or first person accounts, and I think with the increased venues of publication. Now you don't even have to publish a book. You can have a blog. You can write about your own illness experiences, and from these first-person narratives, we learn a lot of different kinds of things. Again, if our goal is to enhance our psychiatric knowledge, one form of knowledge that we acquire from these self-reports is what I think of as orientational challenges, which basically a lot of mental disorders really changes your orientation in the world or how you orient yourself in the world, and we can learn a lot about that experience by listening to or reading what people actually say about those experiences. Another thing that comes through from these first person accounts is what I think of as hyper narrative context. So a memoir or an account of mental illness is never just about like that kind of psychic experience, but also the social context, individuals, kind of embedded environments, and so on and so forth. So we can learn a lot about those kinds of contexts if we pay attention to self-reports. We learn a lot about how different forms of psychiatric treatments might have helped or hindered people's flourishing. And in some memoirs, like Ellen Sachs, for instance, you can kind of see the treatment that she received under a more psychoanalytic framework versus a more, kind of modern DSM framework. And it's actually very telling how she felt that those frameworks help differently to her. And we also can learn a lot about how people engage with their diagnosis, because I think one of the things that happen when people are diagnosed with mental disorders is that the way they think about other aspects of their lives might also change. And I call that reflective impact. And also we learn a lot about coping and flourishing. And again, in a kind of more traditional psychiatric framework, there's a lot of emphasis on the mental disorder, but not enough on how one might flourish withstanding their mental disorder, right? It's almost kind of inconceivable sometimes in these scientific frameworks to think that one might flourish with a mental disorder. So in that sense, I think it's both of these provide very, very important resources for psychiatry that scientific psychiatry should take more seriously. So, but we encounter kind of a scientific problem here. I mean, at least that's been the kind of argument to the extent that why self is not been made part of psychiatric research. One is what I call the Freud problem, and here I don't mean that that Freud is the problem, but rather what people think of Freud as being the problem. Basically, there's this assumption that, like, a false inference that like psychoanalysis studies the self and psychoanalysis is not scientific, therefore studying the self is not scientific. And this is basically a false inference. There are different ways of studying the self that might make it more scientific. And in addition, I think this kind of really misrepresents the kind of what psychoanalytic framework actually might offer even in understanding the self and so on and so forth. And this has been very prevalent, at least in the context of the United States. In the last publication of the DSM-5, there has been a push to categorize personality disorders in a dimensional way that focuses more on kind of personality as a form of measurement. And people who have been inside and involved in these conversations have actually revealed that there has been a lot of pushback against the concept of personality because people really associated that concept with Freudian psychoanalysis, not really kind of embracing the fact that that concept has been studied by cognitive psychology and so on and so forth, right? Another challenge against the kind of incorporating the self in scientific research in psychiatry is kind of skepticism about the reliability of self-reports. So this is a big tradition. This is a big. There's a big literature in philosophy and again cognitive psychology on how reliable our self-reports are. Turns out, in a lot of cases, people's testimonies on their own experiences is not really reliable. We tend to confabulate. We tend to represent ourselves as the hero, not never the villain. And there are certain kinds of biases that we might put in telling our stories. And this kind of unreliability might be more of a problem in the context of some psychiatric conditions or brain injuries. And we might say, well, how are we going to really trust the truth and reliability of self-reports to integrate them into our science, right? That's another challenge. Another kind of version of the reliability challenge is what I call the TikTok problem. By that, I mean there is an increasing attitude or tendency now, especially at least in the context of the United States, for people to self-diagnose their experiences based on what they sometimes see in these TikTok reels and so on and so forth, right? On TikTok, you might see some teenagers like diagnosing, self-ascribing diagnosis to their experiences, and they talk about that, and then then individuals watching them might be influenced by that and kind of start talking about their experiences as if they are mental disorders. This raises problems for the reliability of self-reports again, because a clinician might say, or a scientist might say, well, when a teenager comes to my office, I learn more about the diagnosis and the labels and the symptoms that are listed in the DSM or uttered in TikTok rather than actually what teenager might be experiencing, right? So that might also cast a kind of shadow on how we might use and integrate self-reports in psychiatric research. And the third problem is what I call the objectivity problem. And this was very kind of prevalent. I know in a lot of different parts of Europe, there's a move to incorporate patients in kind of decision making about mental health and mental health care, but that's not really the case in the United States. In fact, before the publication of the last DSM-5, there has been a big call to American Psychiatric Association, who produces the DSM, to involve patients and their families in kind of scientific discussions on how to set the criteria for mental disorders. So there are philosophers, clinicians, and lots of patient activism. At the American Psychiatric Association meeting in San Francisco, there were lots of patients protesting that not being included in these decision-making processes. It was a PR kind of moment for psychiatry, in that American Psychiatric Association's task force, the DSM-5 task force, actually wrote something about why they decided not to include patients in the deliberation processes. And it was something like this. Of course, patient feedback is extremely important in clinical decisions and so on and so forth. But patient reports are subjective. And psychiatry, we are trying to come up with an objective criteria for mental disorders. How are we going to reconcile those? So this is a direct quote from this article that was co-authored by the task force, which says, by definition, subjectivity is variable from person to person, therefore making it impossible to develop objective criteria that will apply to every disorder. Further, it raises the question of whose subjective experience will serve as a template by which criteria would be delayed, right? I mean, you can kind of see the actual rationale behind this. Like, everybody might have different kinds of experiences with maybe the same diagnosis, and how are we going to incorporate those? So I see these as challenges, but not reasons for not engaging with the concept of the self in psychiatry, because I think the benefits that will come from thinking about the self in psychiatry are higher than some of these challenges. So, in that sense, I develop a model of the self. And when I think of a model of the self, I take it very seriously, that like the kind of literature or the way in which scientists think about the subject that they study. The first step for a scientist to study their subject is to actually form a representation, a model of the thing that they're studying, right? And I think of psychiatry as a model building science in which models can be designed for different goals. So if you're a clinician, you're building a model of the patient in the clinic, right? Because you want to help them, I don't know, cope better with some of their challenges. But if you're a scientist, you might create a model of the individual or the self in a way that will help you do genetic research or neuroscientific research or other kinds of research, right? So this multitudinous self model, which I call MUSE in short, is a model of the patient, and it's aiming to offer tools for developing interventions and enhancing psychiatric knowledge. In that sense, kind of these are like the slogans of the model. It is inviting psychiatry to reconceptualize what it means to be scientific by rethinking what it means to be objective. And here I develop a view of objectivity that is heavily influenced by feminist philosophers of science, and I call it participatory interactive objectivity. And the Muse model, this model responds to these three challenges against studying the self in psychiatry. So what I'll do is I'll kind of talk about this model as I respond to these challenges. So first is Freud problem. Remember the idea that the self is not a scientifically, it's not fit for scientific investigation, right? So I'm saying that the model that I develop is actually a very good fit for scientific investigation. Here, what this model is a representation of the complex selves that we all are. And when I think about the self, I think of, in this context, muse, I think of it having 5 different facets. And this is kind of an important metaphor in that these are not parts of the self, but rather think of, having a kaleidoscope, right? You spin, you see a different image and different picture. And I think of these facets as that, right? So the physical facet is the kind of biological, physical fleshes that we are, right? We have a biological system, we have genes and various factors, biological factors that really actually make us who we are in so many ways. The social facet gets to our sociality. We are, since birth, are embedded in social cultures. We literally cannot exist and survive without other people. There is the experiential facet, and this becomes really, really important when we are trying to understand the experience of mental disorders. This is how people experience themselves, right? They might be hearing voices. You might not hear that voice, but experientially, they are telling you the truth that they are hearing voices, right? And the fourth facet is the narrative facet of the multitudinous self model, and this is about the kinds of stories that we tell about ourselves. And sometimes these stories are told to fit in a particular kind of social normative world, or sometimes we just want to tell how we feel, or sometimes we basically want to be liked and kind of might skew how we're telling our stories. So again, reliability or the kind of truth might be really flexible when it comes to our self narratives, but it's extremely important how you construct your self narratives when we think about mental disorders, because that's literally the way in which other people can engage with you, or in the context of clinic, might help you. And finally, the conceptual facet are the way in which we think of ourselves, right? And I think, I don't really get into the metaphysics of how all of these different facets might interact, but my kind of hunch is that, like, over time, as we kind of move in the world, some of our self narratives kind of stabilize more in form of self concepts and so on and so forth. The most important aspect kind of this model of the self is that it's grounded in psychology and social sciences. So I really engage with social psychology, cognitive psychologists and sociologists, and kind of developing different facets of the self, but it's also very responsive to the first person reports and experiences of individuals. So in that sense, it's really engaging with kind of sciences and philosophy as well as first person reports. And I think thinking of this representing the patient in the clinic through the Muse model really gives us a kind of a well-grounded representation of what the patient might be experiencing. In it, like kind of in contrast, right, when a patient comes in, especially if you're a novice psychiatrist or in the context of again United States, you don't even need to have a psychiatry degree to treat patients who are coming to you with mental disorder symptoms. Sometimes clinicians look at them just through the lens of a diagnosis rather than through the kind of a more empirically grounded, holistic perspective. So, in that sense, the Freud problem kind of dissipates in the sense that we can think about the self as a model and find ways for different researchers and clinicians to engage with it, right? The second challenge, again, is the reliability of self-reports, right? So it is true, individuals who are reporting on their experiences with mental disorders might have different ranges of self-reflexivity, right? In that self-narratives are selected representations of the states of affairs in our lives, and they're organized in a meaningful manner, and communicated through language, and kind of that narrative truth may not always be part of those narratives. But I think reliability is overrated in the kind of context of narratives in the context of psychiatry, because ultimately those self-narratives are how people experiences themselves, and that's what the clinician needs to kind of engage with the individual. So the kind of self-diagnosis problem is a huge problem, and a lot of clinicians have kind of disdain to individuals who come to the clinic with a self-diagnosis. I was teaching psychiatry residents a few weeks ago, and when we were talking, they started diagnosing these patients who self-diagnose themselves and come to clinic that way. They start diagnosing them with personality disorders and saying things like they're trying to get attention and so on and so forth. So it's really something that's frowned upon or perceived negatively. But I'm kind of actually, inviting clinicians and researchers to embrace that, people's self-diagnosis, because it's an indication that the person might be in distress and is in search for some kind of meaning. And we do that in a lot of other cases that is not involving a diagnosis, right? We kind of try to make sense of it by creating a story around it. And rather, we can kind of use, like, especially the conceptual and narrative layer of the Muse model to really engage with the individual and try to find out whether their self-diagnosis might be actually accurate, or what they want from that label that they currently do not have that we might be able to provide. So again, when we think about Muse as a lens, as a framework to engage with individuals in developing their care, we can kind of think of these seeming challenges as ways to get started in interacting with patients. Also, another kind of response to this challenge is that the model of the self that I develop is not just grounded on self-reports, but also in research in cognitive and social sciences. And it's kind of trying to triangulate patient experience, not just by self-reports, but also grounded on research in other sciences. So, but what it does is that it's kind of systematically integrates self-reports as a source of information aligning with scientific and clinical knowledge, right? So I developed this kind of strategy that I call trilateral strategy, which is a strategy to engage with somebody's potential mental disorder, where clinician, kind of in this ideal world, is someone who's trained in the science, right? They go into medical school, they get a lot of training on treating patients, so they have some kind of clinical experience and background, but they're also individuals who are trained in cognitive and social sciences, as well as receptive to, or have a lot of encounter with patients' self-reports, that they are able to kind of provide that synthesis in their engagement with patients, right? So reliability of self-reports may not be as big of a problem if we think of it as a source, like one of the sources, as much as scientific and kind of clinical sources. And in some ways, Muse really tries to provide a platform where all of these diverse sources of knowledge come together in building a model of the self, a model of the patient in the clinic. And finally, the objectivity problem. I see this also as a kind of way to an opportunity for psychiatry to rethink what kind of psychiatry, what kind of science it wants to be. In that kind of big diagram where I show the history of the DSM or history of psychiatry in the United States, when psychiatrists early on in kind of really dealing with this challenge of not being taken seriously as a form of scientific discipline, when they wanted to establish themselves as science, the model of science that they looked up to was physics, and that was kind of the paradigmatic science of the time, and it was very heavily influenced with this idea of operationalism, where scientific phenomena, we try to find observable operations of scientific phenomena to study them scientifically. So I'm basically inviting psychiatry to kind of expand its notion of what it means to be science. So what that means then is, like, remember, DSM is basically, the DSM creators were reluctant to involve patients with direct experience of mental illnesses in the scientific deliberations. But we can actually use that as a way to kind of reconceptualize science. So in that sense, I kind of make, two interventions here. One is, I argue that psychiatry's notion of expertise has been limited primarily to those with training in psychiatry, and it did not include patients as possible experts, where I'm inviting for patients to be regarded as experience-based experts. So again, being a patient makes your contributions valuable, but it doesn't necessarily make you an expert immediately in this kind of picture, where I define kind of patients are experience-based experts if they have the experience of mental disorders and can articulate these experiences using their self-reports, and who have learned from their experiences over time with skill and effort by observing their own experiences as well as those of others, right? So it kind of requires, if you were diagnosed yesterday with, schizophrenia, today you can't really be an expert, but over time, by kind of engaging with people with similar experiences and so on and so forth, you might develop expertise. So in this picture, and this is kind of a big response to psychiatry, is this idea that involving patients will not make us scientific. It's actually not true. We can see other moments in history of medicine where patient involvement made actually a big difference and helped develop scientific frameworks. My example is activism around HIV and AIDS in the 1980s, when it was a huge problem in the United States, and it was thanks to the activists' efforts and their volunteering in various clinical trials and literally pushing the FDA to start clinical trials with some of those experimental drugs and so on and so forth, that really helped make progress in the kind of scientific research on HIV. And I think psychiatry can really learn a lot from these past practices of patient involvement and how they advance psychiatry. So how will this work? So again, remember, psychiatry says, well, we're trying to be an objective science, and including patients' self will not make our science objective. In response, I developed this idea of that I take objectivity to be a participatory interactive process. Again, this is influenced by feminist philosophers of science who think of objectivity not as like something that happens at the end of scientific inquiry, but rather the process in which we do science, right? And in a way, it's kind of representative, actually, the current ways in which scientific research happens, right? You work in your lab, and there's lots of collaboration and different kinds of expertise. You have like undergraduate research assistants to graduate students, and and then you write a paper, you send your results and paper for publication, and there are other experts chime in, may or may not find your scientific research as kind of valid, and that interaction happens, and then results with like scientific product. So in that sense, science is an interactive process, and psychiatry can embrace that by expanding kind of the notion of objectivity to mean something as a feature of inquiry in psychiatry. So in that sense, we are kind of imagining this interaction, just like between the peer reviewers and the undergraduates in your lab and graduate students and you as a scientist, to kind of involve different kinds of experts. So these experts include then scientists who have the technical expertise. These might be researchers with an MD degree who studied science and neuroscience and so on in understanding mental disorders. It involves clinicians, and not just psychiatric clinicians, but also counselors, psychologists, and social workers, psychiatric nurses, other folks who are encountering patients daily and developing knowledge about those particular cases, and first person, experts by experience, people who have the expertise to, who have the experiential expertise to be part of that scientific process. So we're kind of like now imagining this world where there's an interaction between scientists, clinicians, and patients to develop knowledge about what will help individuals at the end. So I kind of think of this as a, like, I don't know, pipe dream. I don't know, at least in the context of United States, I can't really see this ever happening, but it might be in other parts of the world. This is an intrinsically value-laden process. We need to establish avenues for criticism and interaction to make this possible, which will involve things like an understanding of shared intellectual authority. So I can see clinicians or psychiatrists or scientists really not wanting to sit in the same table with patients, thinking that, well, they don't have the expertise, I have the expertise. Similarly, some patients might not want to regard these individuals as experts, especially if they had some negative experiences in the kind of psychiatric systems, right? So in that sense, we need to do a lot of work to build trust and respect and openness to criticism in these communities to make this kind of happen. So nobody gets an automatic epistemic privilege, for instance. And that might be hard for some participants to kind of accept. And again, I can see tokenism where, we have one patient representative and then, majority is like the other, and that person is there to kind of almost expected to rubber stamp things and so on and so forth. So we don't want that. I mean, on the one hand, I'm kind of negative that, I'm not optimistic that this will be attained, but I think there are lots of local successful examples of these kinds of interactions yielding positive scientific outcomes that we can talk more about in kind of Q&A. So to kind of bring all of these threads together, at the University of Texas at San Antonio, where I was previously located prior to my current position, I work with an amazing group of colleagues in psychology, and they are mostly doing research in PTSD and traumatic brain injury involving veterans. And most of their funding for their research comes from the VA, like Veterans Affairs in the United States, and they tend to have more holistic measures and holistic interventions, primarily because they're really, really invested in helping those veterans to recover fast so they could go back to the service, or they're really kind of, a high prevalence of them developing substance abuse problems and so on and so forth. So there's a lot of investment. So my colleagues were very intrigued by this model of the self. So again, I'm not by this example by no means shows like the amazingness of my muse model. It's a very, very limited study. But what we did as a group is they already had so we wanted to understand whether the facets of the muse model says anything important or anything relevant about the possibility of the veteran groups, veterans developing substance use related problems. And they already had an existing inventory, and that was a very detailed inventory of data that involved their more kind of objective measures of like physical health and their self-perceptions and so on, but also self-narratives and self-reports. So what we did is we leveraged basically the survey amongst veterans based on that scale, and examined like the explanatory resourcefulness of the Muse model in predicting whether or not they will develop substance abuse. So, and this is a really helpful picture, I think, to kind of understand the different facets, what scientific or empirical research in each of these facets might mean. So for the physical, we looked at the measures of diagnostic codes to see if they had any existing health conditions like prior mental health issues, insomnia, anxiety, pain, hypertension, high blood pressure, and so on. So like a very big inventory of physical health status. For the social facet, we looked at the kind of their perceptions of qualities of relationship and community. So basically how, whether or not, how well they reintegrated back to the society after separation from military service. Did they come back and start living alone, or did they come back to, supportive families and so on? And this was based on patients, individuals, like self-reports on how their social interaction was, integration was. And for the narrative, we looked at how they perceive their emotional health over time. Do they think that they're doing better than 3 months when they first came back, and so on? And this was, we use a measure that asks the respondent to compare emotional health to over a year ago. And for the experiential, we looked at their individual sense of their experiences. So this was basically again, a kind of a temporal study of the severity of common somatic symptoms, like insomnia, cravings for substances, and so on and so forth. And again, this was like a very private experiential report. We looked at their self-reports to kind of track that. And finally, for their self-perception, their perceived confidence in their ability to complete life tasks. So this is basically a self-efficacy task. And again, we looked at data that tracked information about their perceived self-efficacy. What we found, interestingly, was all of these different facets of the Muse model were correlated with substance use development risk, in that each of the kind of, if you had like their perceptions of health over time, for instance, if that kind of declined, then there was more likelihood of developing substance use disorders. But there was a very, especially strong relationship between their social integration and their likelihood to develop substance abuse, meaning, if they had a more supportive environment where they were integrated easily, they were less likely to develop substance use. So, I mean, we could have drawn this kind of prediction and inference somehow. But again, at least in the context of the United States, a lot of research funding goes into studying more the kind of physical underlying factors in substance abuse, and less on the kind of social factors. So I think a model like Muse really can shed a light on these previously underexplored themes that might help us have access to understanding the kind of progression of mental disorders. So in a way, my kind of like take-home message for this book is that if psychiatry is going to be more scientific, humane, and effective, a conception of the human self needs to be integrated into its core. And this kind of concept of the self has to be comprehensible and actionable. It draws on research across disciplines and levels of inquiry. So interdisciplinary research is really, really key here. It adopts an expansive notions of objectivity and expertise. And I think it can serve psychiatry's goal to guide interventions to treat disorders and improve health. And it can also guide individuals' flourishing. One of my favorite aspects of the model of the self that I did not kind of develop as much as I would have liked in the book is this idea that I'm kind of inviting to think about mental health in a way that is divorced from mental disorder. Because when we think about mental disorders, we're really fixated on this kind of anomaly, health related, like concern and something that's distressing. But if we start thinking about, maybe some of these distressing experiences as part of this kind of diverse experiences involving the self, then we might be kind of more open to different ways of cognizing or being in the world. When we think about, for instance, like the neurodiversity movement or Mad Pride movement, we can kind of involve all of those scales into kind of our understanding of mental health. And I hope that I get to think more of that kind of research. And thank you so much for your attention.